Let me get. All right, everyone. Good morning. Good afternoon for some who are not in the Pacific. My name is Andre Sueur, and I am a second year resident from UC Davis, San Diego Veterinary Medical Center. And today we're gonna talk a little bit more about this manuscript entitled Upper Urinary Urolithiasis in Cats with Chronic Kidney Disease, the Prevalence and Investigation of Serum and Urinary Calcium Concentrations. The study was conducted by Dr. Tsu and Takamura from a study group in Japan. And I hope we can talk a little bit more about it. Um, why I feel like the more often that I see the feline population with chronic kidney disease and nephrocalcinosis or upper urinary tract obstructions, I think it's really important for us to talk how important renal mineralization is an acid pathological finding in feline chronic kidney disease. So it's important to remember that as chronic kidney disease develops and progresses through this cat's life, we already know that phosphate retention and accumulation of fibroblast growing factor 23, as well as the diminution of clotho, will promote altered calcium homeostasis and so on, develop as we now called bone and mineral disorders related to chronic kidney disease. And further on, we already understood, especially for us who are doing the residency program, if we go back to some of our lecturers towards nephrocalcinosis and what's happening to that particular population of cats. We also learn that the so-called random plaques, and the structures of how the punctuate or the mixed pattern or striate, as Dr. Jody Lulich just published recently on his findings, will certainly will lead to that tubular obstruction, urinary impairment outflow in that tubular segment. And interestingly, the hypercalciuria states seems to be present and persistent throughout these cats' lives. So it's a vicious cycle that will potentially will accelerate the progression of chronic kidney disease. So before we actually start talking about the manuscript, I think it's important to highlight some other studies that will contribute to the following one that we're gonna mostly talk about. So back in 2022, a study group from RVC did a retrospective cohort study to identify nephrocalcinosis risk factors and also evaluate the influence on CKD progression and all cause of mortality. And the study aimed to quantify, actually, sorry, the calcium deposition histologically at the von Cossa red stain, as you can see here, and report the risk factors and clinical outcomes measured in 51 client-owned euthyroid cats with chronic kidney disease in between iris staging 2 and 3. And according to their findings, the nephrocalcinosis prevalence was extremely common, with 78% with mild to severe nephrocalcinosis. And only 22% presented absent to minimal nephrocalcinosis. So this is really also important to understand that the minority also somehow had a minimal percentage and presence of nephrocalcinosis. But the most interesting thing was also that the independent risk factors, such as the total calcium, not the ionized calcium, had a three times increase odds or threefold for every 1 milligram per deciliter in increased total calcium. So what does that mean? It means if you have a cat with a total calcium of 11 milligrams per deciliter and another cat with 12 milligrams per deciliter, so that second cat will have a three-time likelihood to develop nephrocalcinosis compared to the previous cat. And interestingly, they also found out that the consumption of phosphate-restricted the phosphate-restricted diets, such as our commonly prescribed kidney prescription diets, um, in the composition of a calcium to phosphate ratio in between 1.3 to 2.1 was also associated to a 5 to 8 times greater odds of nephrocalcinosis. But we have to be a little judgmental on that because the majority of these populations also had chronic kidney disease. And there's also the discussion to understand if the more advanced chronic kidney disease more likely to prescribe a renal diet and more likely to develop renal mineralization. So these when we see as part of our retrospective cohort studies, this is the question marks that we don't have the control, but we will look on our results. But interestingly, on top of it, there is also unexpected findings where cats with little, which means the 22% group with little or no nephrocalcinosis, they demonstrated a faster increases in creatinine, in urea, and in phosphorus. And I apologize for the small graph, but I can give you a zoom here, and also shorter survival times for those who had minor or little nephrocalcinosis. So that is another discussion in the manuscript that um, perhaps these the cat population analyzed those with chronic kidney disease. Perhaps they had a more aggressive and progressive chronic kidney disease with earlier death and less time to mineralize versus those cats with longer survival. They have more time to develop nephrocalcinosis and more calcium deposition. But what we took as a full disclosure for this manuscript, we understand that the higher total calcium at with in association with the diagnosis of chronic kidney disease and the consumption of protein and phosphate restricted diets are independently associated with nephrocalcinosis. But the nephrocalcinosis was not associated with the rapid progression of cats with CKD. And moving on to the same school 2 years later, they decided to actually now do a prospective cohort study to identify the risk factors in association with ultrasound diagnosed nephrocalcinosis and also evaluate the influence of nephrocalcinosis on chronic kidney disease progression. This prospective cohort study, sorry, included 36 cats with chronic kidney disease, and all of them underwent ultrasound performance. And based on these findings, the variables with biochemistry and other I'm sorry, other other analytes were studied, and their major findings were that at enrollment, the high blood ionized calcium concentrations, the plasma phosphorus, and the plasma creatinine, as well as the alanine aminotransferase, were independent risk factors for nephrocalcinosis. So as we also understood from the previous study in which was enforced in this one, the prevalence in this cat population now, this living cat population instead of the post-mortem previous cat population, 81% of cats with chronic kidney disease had I'm sorry, had hypercalcemia with nephrocalcinosis, but overall 61% comprehended that. Um, and um, and the odds ratio for ionized calcium and serum creatinine was similar, 1.27 and 1.29. And as well, the phosphorus was 1.16 milligrams per deciliter. And cats with chronic kidney disease and nephrocalcinosis had increased plasma creatinine concentrations and also decreasing body weight over time. So there was progressiveness of such biomarkers, but also the drop of the body weight of this population. So, as a conclusion, with the ultrasonographic findings before the postmortem as mentioned on a previous study, now the mineralization would represent an active disease process rather than just incidental ultrasonographic finding. So, what about FGF23? This The same group that I am presenting the study today also did a study related to the association between the FGF23 concentrations and the blood calcium levels, ionized and total calcium, in cats with chronic kidney disease and upper urolithiasis. And for this particular group, they like to mention upper urolithiasis, such as nephrocalcinosis or presence of ureteral obstructions, not only nephrocalcinosis. And this population, they analyzed 32 cats with chronic kidney disease with upper urolithiasis, and they measured the total calcium and ionized calcium, and as well FGF23, creatinine, and phosphorus, and such other biomarkers, but mostly representative for the discussion. These ones that I just made a summary here for you guys. And the group found that despite of being ionized or total hypercalcemia, this cat population also presented a higher concentration of fibroblast growing factor 23 compared to the population with normal total calcium and normal ionized calcium. There was also a positive correlation in between both, but not significant correlation for creatinine and FGF23, as well as for phosphorus and FGF23 in that particular population. So the study provided the mechanistic evidence that abnormalities in mineral metabolism, including now FGF23, the hypercalcemia, regardless if it's total or ionized, had an association with nephrocalcinosis and upper urinary tract stones disease, independently of creatinine and the phosphate status. So, with this previous background, I this is maybe because during my residency do have the we do have the particular exposure to the diversity of this feline population, especially after sub placement. So we learn that we need to measure not only calcium, but sorry, total calcium, but also ionized calcium. Now we have FGF23 in practice as well. We measured urinary active injury biomarkers just to understand, especially for this population that do have obstructions, upper urinary tract obstructions, and just try to monitor their kidney function, especially when there's no fluctuation in their functional biomarkers. We also monitor their UPC. So it always brings me the question because now our clinic receives a lot of these younger male, the majority are male cats with bilateral or unilateral stents placements, and then we have to do their managements. I mean, what else can I offer? Because I'm not seeing more ionized hypercalcemia in these cats. I'm not seeing hyperphosphatemia. I'm not seeing FGF, an elevation of FGF23 that will make me more considerations about disease progression, neither presence of active injury biomarkers in that sort of population. But as a resident, and especially towards that particular population, which they almost died because of a obstruction, maybe bilateral, maybe unilateral. And now they do have a $10,000 device inside of them that we need to manage them. I mean, I wonder what can I offer for this cat to be in a bubble and protected from the of him maybe forming a new stone or that nephrocalcinosis getting worse, and how can I prevent that disease progression and in association the extension or the worsening of this patient's chronic kidney disease at early stages. So the manuscript that we're going to talk about has two different objectives. The primary objective was to determine the prevalence of upper urolithiasis in cats with chronic kidney disease, which seems to be pretty often analyzed as I previously described on these three previous manuscripts. But the secondary objective, which was the main reason why I wanted to talk about today, was to compare not only the total calcium and the ionized calcium of that population, but also the fraction of excretion of calcium in that particular population, as well as the urinary calcium to creatinine ratio, which is not a commonly often test that we do for cats. And if someone does it, I mean, maybe this is the reason why this discussion today will open a better enlightenment to that particular case selection that we keep seeing at our clinic. And that comparison was, of course, in cats with and without upper urolithiasis with chronic kidney disease. So the study design is also a retrospective observational study from the Life Science Nippon Veterinary University in Japan. The study period was designed between 2013 to 2021. And this large population of comprehended 140 cats diagnosed with chronic kidney disease from a referral nephrology and urology population. So they mention that three times in their manuscript. Like this study was actually a clientele that will come to the university for a second opinion from the specialist. So these cats were already diagnosed and treated on their primary specialists. And as a definition, so the definition for them of chronic kidney disease, these cats should have renal azotemia with ultrasonographic renal abnormalities, at least persistent for over 3 months, with a creatinine greater or equal than 1.8 milligrams per deciliter, and a urinary specific gravity lower than 1.035. And for the diagnosis of the nephro or urolithiasis, it should be done by abdominal ultrasound performed by an experienced nephrologist, as the definition of hyperechoic structures with presence of acoustic shadowing and located in the renal pelvis or in the ureter. And if they were present, then later on they were further characterized as unilateral or bilateral. So for the initial cohort, they assigned 140 cats with chronic kidney disease. And from that population of 140, the 102 cats, 73%, presented upper urolithiasis, either nephrocalcinosis or presence of ureteral lithiasis. And 38 cats, which means 27% of that group, had no urolithiasis at all. And the median age for those who had presence of urolithiasis were lower than those cats with only chronic kidney disease. They were leaner with a body weight of 3.8 kilos compared to 4.1. The sex of these 38 CKG cats were consistent of 20 castrated males, one intact male, and 16 spayed females and one intact female. And the likelihood of the cats with chronic kidney disease with upper urolithiasis were more likely to be pure breed, and were also fed on a dry food only and fed urine acidifying food only as well, compared to cats without upper urolithiasis. This is going to bring another interesting discussion as well further on. So the problem was that on that cohort retrospective study, among that 140 cats, only 50 cats had preserved urine samples to do the second part of their analysis. So then what the authors did, they divided that 50 cats into groups as urolithiasis group and control group. And here is where we see a big gap, especially for statistical power, where we have 41 cats comprehending 5 cats at stage 1 chronic kidney disease, 25 at stage 2, and 11 at stage 3, and only 9 cats as a control group with no cat at non-isotemic or at CKD stage 1, and 4 at stage 2 and 5 at stage 3 chronic kidney disease. So they measured and compared between the groups serum and urine analytes, and most of them were creatinine, BUN, phosphorus, total and ionized calcium, electrolytes such as sodium, potassium, and chloride, as well as bicarbonate and total protein and albumin. And in the urine, they only measured the urinary specific gravity, and the fractional excretion of calcium, as well as the urinary calcium to creatinine ratio. And I presented the formula here for those who are not familiar. But interestingly, and this is what I've been researching before this presentation, I mean, some of us do fraction of excretion in our patients, but still, it's quite hard to find. We know that the fraction of excretion of calcium in the feline population is similar to sodium, sometimes like lesser than 1%. But we don't have a strong publication that is easy to find online to understand what would be the cutoffs, or I don't even know if someone ever did a study with these cutoffs, but that will be another important point for discussion. And so on, the same apply for the urinary calcium to creatinine ratio, because even though the authors did not mention in their methodology or in their discussion what was their condition to define if the calcium to creatinine ratio was greater or lower than 0.05 as we somehow use for dogs with hypercalciuria, especially for the recommendations of introducing a thiazide. That was not unfortunately mentioned on this study, but I feel like this is why is the reason that I'm trying to present this manuscript and share that with you guys. Um, so for statistics, data normality was performed under Shapiro-Wilk test. Statistical significance was with a p lower than 0.05. For the category of variables, chi-square test and Fisher's exact test when appropriate. For the independent risk factors, of course, the univariate analysis for the multivariable binary logistic regression, not rejection, regression analysis. And when we want to compare groups for the continuous variables, the two simple t-test and Mann-Whitney u-test. And for the model validation, they used the Hosmer-Limshow and the goodness of fit test. So for the results, as we can see, some of these findings are pretty similar to what we've heard or we've read in previous publications. what I just as a clinical and critical thinker, I just feel like this control group of 9 cats somehow underpowers um, or I would say will can compromise the actually the p-value of both groups. I mean, I wish there were more control groups so we can have a better understanding. As we can see here, there is no difference in the creatinine, the BUN, total protein almost there. Albumin was also not significant, neither for phosphorus, sodium, potassium chloride. But interestingly, the USG of both populations were pretty similar. And especially, it's interesting to remember that the population here that we also are analyzing, these cats, they were not fed under a kidney prescription diet. They were like under a urine acidifying diet. So this is another potential uh, risk factor, or how can I say that? It's just another potential factor that might be like a contributing factor. That's the right word. A contributing factor for us to see if the chemical components of that diet could interfere, especially on the urinary findings. So on the USG, on the fraction of excretion of calcium, and in the urine calcium to creatinine ratio. And based off what I was assuming, because there's not a good discussion about, I am assuming that the study group actually tried to use the same measurement as we used for dogs, as a greater than 0.05, just to understand the difference in between one to another, and the fraction of excretion. It's pretty hard to understand what was their cutoff because they also don't mention in their discussion, which makes it a little hard to interpret it. But I made a little summary here in the results. So what the study group found was that cats with upper urolithiasis were more likely to receive dry food only, corresponding 65.7% of the population studied, as well as they were under a urine acidifying diet, corresponding here almost half of the population with 41.2%, versus those with no urolithiasis were not under a urine acidifying diet, and neither, I mean, in a much lower dry food only fat mechanism. And on the multivariable logistic regression, the independent risk factors were that the purebred status, so the more purebred the cat will be, the odds ratio for them to have nephrocalcinosis or upper urinary tract obstructions were more likely so, and as well as the dry food only. Both were statistically significant. So, the authors also mentioned, I almost forgot to say, the authors also mentioned that they only had 7 stone analysis from this large group population, and that seventh results were consistent with calcium oxalate stones. So then it leads to the clinical interpretation that could these cats be under a wrong diet, maybe because they should be on an early chronic kidney disease diet prescription, or shall they be under that particular diet just towards prevention of the RSS oxalate and calcium oxalate promotion in the diuresis. So this is what I will bring that to the discussion today, but also the calcium findings there was no difference in total calcium, but a statistically low statistically, but significant a hyper ionized calcemia was higher in stone forming cats, as we also noticed in the previous studies. Excuse me. And they also mentioned that the fraction of excretion of calcium, as well as the urinary calcium to creatinine ratio, both were higher in cats with upper urolithiasis. But again, I feel like if we just go back here and we look towards our control group and our population with upper urolithiasis, I feel like I'm still in doubt, like what would be the true power if we do have a better control group. And I also would bring the food for thought if the acidifying diet could be another contributing factor for having these higher numbers in such population as well. But I'm also open to listen once we can talk better about as a group. But interestingly, here the group presented so the correlation with the groups and the statistical significance in between those with urolithiasis and control. As we can see, the ionized calcium was statistically significant, as well the fraction of excretion of calcium and the urinary calcium to creatinine ratio, but not total calcium, neither phosphate or creatinine. So for the discussion, so the progression of chronic kidney disease and the mortality rate in cats and humans with nephrolithiasis, there is a limitation of being as a retrospective study. They also mentioned that their population had younger cats, and they used a reference of the majority of population, as I believe it's a study from Dr. Ross, where in that particular community, the median age was 7.3 years, and their population is much younger. They also mentioned that the dry food and urine acidifying food associations, interestingly, also no significance in the urine specific gravity. And then there's like a big gap of discussion here that we can talk more about chronic kidney disease and the USG and contributing factors and how the diet will play, especially a urinary prescription diet compared to a early or late stage kidney prescription diet. They mention about hypercalciuria on both tests, but it also they do not, I mean, unfortunately, they don't discuss more depth about the reference of validation for both of their findings. So, which makes it challenging to understand what were their cutoffs to understand the power of significance in the study. But I've been very curious if someone has been doing either the fraction of excretion or the urinary calcium to creatinine ratio in the feline population, and then it leads to a following question: do cats with chronic kidney disease and upper urolithiasis would have evidence of increased urinary calcium excretion? But then of course, we're gonna need a bigger group of like the feline population with chronic kidney disease and no signs of mineralization whatsoever to understand if the hypercalciuria might be another risk factor. But how do we measure it? What's the cutoff? So these are the gaps that we still don't know. And I wonder if someone or sometimes like one of our professors from the universities who is doing some ongoing research that they can talk more about. I would be very, very grateful to hear from you all, because I think the more we see this population in our clinical practice, where now they're not hypercalcemic, their phosphate is normal, FGF is normal. So what can I do? But they do already have the evidence of mineralization in the upper urinary tract. And just for full disclosure, this graph down here, which I found, this is a abstract from the WA as uh, AVA, the Wasava, in 2016, where a Brazilian study group from the University of São Paulo, they measured the urinary fraction of excretion in a population of cats with chronic kidney disease and without chronic kidney disease. And in between both groups, they also were analyzed with calculi and without calculi, which is pretty similar to what they found here, which is what was quite interesting. But also, because it was an abstract, there was no mentioning what would be their cutoffs to call as increased or normal for such population. Um, just for sake of time, so the strength of limitation of this manuscript, I found that the strength, it was a clinically relevant population for the disease group. So 140 cats. It's a substantial group, and they measured ionized calcium. They were able to measure the urinary calcium excretion, which, I mean, in my clinical practice, it's quite expensive sometimes to overcharge my clients, and I don't know what to do with that number or what shall I prescribe. So I think it's a starting study for us to move forward and understand how this population is actually behaving. Um, they presented a multivariable analysis performed, and they addressed the understood mechanism, although I mean, I'm still a little skeptical about their control group and how that would negatively impact in their statistical power overall in the end, their significance power. But the limitations was also retrospective design. It's a referral population, so it can be biased. A very small control group of nine animals only. Only 50 cats had urine available. I believe the dietary was a major impact. Surprisingly, for like 50 cats with chronic kidney disease under a urinary diet, that I think this is something that should be better spoken in their limitations or in their discussion. And I also missed that in that manuscript. Um, no access towards parathyroid hormone or the receptor or calcitriol data was explored. And as well as, since we're speaking of a urinary prescription diet, they also did not include what is the urinary pH data of this cat population. So I believe the clinical relevance is important to monitor ionized calcium in association with total calcium. Now, whether the usefulness of the fraction of excretion of calcium or the urinary calcium creatinine ratio in normal calcemic cats, I mean, what are the treatment options if we do find hypercalciuria in that population, but now they have early CKD? Or if not yet, if they still can concentrate the urine, but they do have some degree of mineralization, then I think it's important to understand that we still don't know like how much more we can prevent. Um, they also mentioned to increase water intake strategies. I mean, the more wet diet, this has been shown that is also a great preventative for reoccurrence or worsening of the calcification in this population. Again, the nutritional impact, so the role of acidifying diets versus what we have now as an early and advanced CKD kidney prescription diets, um, and the hypercalciuria, as I previously mentioned, in cats with normal FGF23 and normal ionized calcium. Where do we go from with that information? I did some further deep studies towards Dr. Bartges and his study group back in Tennessee. They did a long-term administration of hydrochlorothiazide in I think in a population of five cats. And he mentioned in his manuscript that a prolonged prescription of thiazides in the feline in that particular not so sick population, but I believe it was like more healthy cats. They he noticed a depletion of calcium and sorry, potassium and magnesium in that population. So we still have to monitor the magnesium and potassium in that population if we are going to plan somehow follow the canine model where we have to sometimes associate potassium citrate with hydrochlorothiazide just to keep up the potassium, and the citrate also is another contributing preventative for the calcium oxalate stone formation. So I will open a microphone if someone does it. I think this is more the most important topics of the of the manuscript itself. But I can't see. Let me take here the laser because I can't see who is here. We have 9 participants. But if someone does it, I mean, or if someone wants to talk about if you guys do that in that feline population, I mean, I'm more than welcome to hear comments, suggestions, what do you do or what you don't do, or if you prescribe something, or because I feel like we learn water intake, dietary management, and especially the calcium and phosphate ratio. Dr. Parker also mentioned that in her manuscript. But all of that population is usually for the feline population with hypercalcemia. But I'm still like going even back to the population where I'm doing a subflush in a cat and his FGF is brilliantly normal. Ionized calcium, total calcium are normal, normal phosphorus, um, um, non-azotemic or uh, stage 2 chronic kidney disease with a dilute urine because of the disease itself, or just because the clients are being very thorough in adding more water or providing only wet food. So the microphone is open now if someone wants to bring up any comments. And if not, I mean, hopefully someone uh, under a big study group doing research can bring that answer for us anytime soon. I'm sure there's someone investigating that, but I would be more than pleased to understand if what else we can add for this population um, in a in ahead of time instead of just watching these animals potentially reobstructing again or having a worsening of their nephrocalcinosis, especially when we're doing everything right and the numbers are normal, but there is progression. We know that. So if does anyone want to talk about it or share anything?
Hi, thank you very much for your presentation,
Yeah, of
review of
course.
the literature. This is Federica from Purdue. Um, I
Hi, Rika. Thank you.
I have we have few cats where we measured it, but it was more for curiosity because, as you mentioned, we don't know how to interpret them, so
Mhm.
we don't have any reference range. So
Right.
we don't know what to do with the number. From what I remember from all of our chronic patients, we have one cat on hydrochlorothiazide, and she's on for years. I don't remember if we started or the primary vet started. We keep decreasing the dose, but the owner is really reluctant to stop.
Really? Hmm.
Yeah, the cat is,
Wow.
I guess, tolerating it and has a stable disease. So probably that's why the owner
Hmm.
doesn't want to stop. Obviously, the cat has a nephrolithiasis and had
Hmm.
had a sub. and we have to remove the sub for, I think it was a
Right.
chronic QTI. So, I mean, well, the cat went through a lot.
Mm-hmm.
Um,
Mm-hmm.
so, yeah, so I agree with everything you said. We don't know how to interpret them and what to do with that
And
number.
and for your particular patient, did you use the same ratio for dogs, and then you were titrating the thiazide and understand if the hypercalciuria was being well managed,
Yeah, I
or
think that is also a tricky question because even the Furrow at the last conference says that she doesn't truly have a referencing dogs. It's mostly on the presentation,
right?
and sometimes she started the hydrochlorothiazide even when the ratio is around zero point 0.4. So, um,
I
I-
know, I
yeah,
know, I know. Welcome to my, I mean,
yeah,
I'm not
yeah.
alone. I
No.
appreciate you for sharing because I mean, this is real, like literally what I've been seeing more and more often. I mean, this is like there's like every month there's a new cat with a sub coming for a sub flush as a referral from a primary care, and they're like,
Mhm.
okay, now he's all yours. And I mean, you don't see, or you see the progression, but very slowly. And still,
Mhm.
FGF is normal, the phosphorus is normal, normal ionized and normal total calcium. Like we're measuring everything in these patient population, and sometimes
Mhm.
you still see, but now I just like struggle if I should do. I wish some of founding members were here so then they could just give
Yeah.
us like an insight if a fraction of excretion is better than is more accurate than the urinary calcium to creatinine ratio for this particular population. But it it's really
Mhm.
challenging. It's really challenging, and I mean, shall we consider like a thiazide for a cat and see if they improve? But I mean, some of these cats, and Cicero himself, he does not like to drink water a lot. So it's a big fight in between the client and the cat for him to drink more water
Mhm.
because he is very particular. But still, I mean, he's doing great, and but yeah,
Yeah.
I'm always in that question. What else can I offer or what else can I monitor before I see this cat re-obstructing or the sub now having complications
Mhm.
or the other kidney that does not have a sub then starts to mineralize or perhaps obstructs.
Yeah.
So it's just but that's and did you see any I was reading some manuscripts for humans with chronic kidney disease, normal calcemia but hypercalciuria. And they mentioned that the diuretics itself um, um, they can also dehydrate the patient. Did you see an elevation of your functional biomarkers like the creatinine, the BUN, and STMA, or no? Like was your cat pretty stable towards the kidney function biomarkers
Yes.
when you introduced
Yes.
that?
She was stable. Yes. Hmm.
And also for the potassium, did they develop any hypokalemia at some point, or did you introduce the potassium um,
This cat was
gluconate?
also on potassium supplementation. Yes. Yeah. Yeah.
Cool.
Um, I think, yeah, I agree with you. And I'm not sure if I don't remember if Dr. Furrow mentioned that if she has any study on this in cats, but it would be nice to have more data for sure.
Right, right, right. Oh, thank you very much for sharing, Francesca. I appreciate you. Thank you.
Thank you. Thank you.
Yeah. Is there anyone else that wants to put their thoughts or their experience in practice? All right. Well, if someone comes to watch it later on, and I mean we do have our core curriculum wall there so we can talk and discuss more. But I appreciate you all for joining me this morning or this afternoon. And hopefully we'll see next time soon with another journal club presentation. But thank you, Francesca, and wishing you guys a great day ahead. Thank you.
Thank you. Thank you.
Thank
Bye.
you. Bye-bye.